I think that one question that we need to be asking still is, does remdesivir work? And it's a question that, based on the emergency use authorization and the prior studies that Gilead and the NIAID have conducted, Gilead would argue yes, and I would argue at a minimum we don't know. And the Solidarity authors from this new study, which by the way is the largest study to date, pretty forcefully argue that the answer is no, it's not effective for hospitalized patients with COVID. So we should be asking that question. And the more and more data that accrue, the more and more it looks like the answer is no.
Wow. So, Steve, is it possible that this treatment actually works better for people before they're hospitalized than it works for people once they are hospitalized?
It's certainly possible. One of the things that's been lacking from the data in hospitalized patients is evidence that the drug accelerates clearing of the virus. And that may be because it's just difficult to measure that in patients in the hospital. It may be too late to do so, but that is the purported mechanism of this drug. Now we have data from Regeneron and Eli Lilly recently from their neutralizing antibodies that shows you can measure that in outpatients. And so, number one, the mechanism lines up with it potentially working as an earlier treatment. Number two, you appear to be able to measure that more readily when used as an early treatment. And the last thing I would say, though, however, is that we don't have any data in that setting from remdesivir. So it's simply way too premature to expect it to work in those patients.
Steve, I want to make sure I'm understanding what is the back and forth between the World Health Organization on the one hand and Gilead on the other. The World Health Organization has come out with data that it says calls into question the effectiveness of remdesivir for hospitalized patients. On the other hand, Gilead criticizes that finding by saying, as I understand it, in effect, we have other data that are peer-reviewed and thoroughly vetted, as opposed to the WHO data that indicate that it does work. Am I understanding the fundamental conflict correctly, and that it is over whether the WHO's data is as thorough and peer-reviewed as that which Gilead says it has?
In part, I think you are, and I agree that peer-reviewed data is certainly better than data that have not been peer-reviewed. That's to state the obvious. But I will say a couple things here. First, the early data on remdesivir came in waves of uncontrolled studies, in clinical case reports, in studies that in some cases were open label, not blinded. And we should be treating all data with the same rigor here, including Solidarity, which is in aggregate 3/4 of the totality of data available on remdesivir now. That's stated by the authors, not me. And so I think we need to take this new data into account, as we have throughout the pandemic for, I should mention, by example, hydroxychloroquine. This is a drug that early on, it was as sensible to test as anything, including remdesivir. It turns out it doesn't work. And I'd be remiss if I didn't mention the Solidarity study also demonstrates that hydroxychloroquine doesn't work. And I don't think that Gilead or others would refute that finding. So we need to look at these new data in the context of all of the data. And the Solidarity study is actually not inconclusive. It's pretty conclusively says there's limited to no effect of remdesivir. And so we need to go back and reassess all of the other studies in the context of this new finding.
Well, Steve, it's Meg Terrell. I want to ask you more about that. You conclude your note by suggesting not only that Gilead reconsider what you call its knee-jerk dismissal of the trial, but also reassess the clinical value of remdesivir in the context of these new data. We are seeing calls from some doctors that Gilead needs to lower the price of remdesivir based on these data, or that the FDA should revoke emergency use authorization based on these data. What do you think should happen?
Well, I get both of those seem like reasonable things to discuss. Again, I would note that revoking emergency use authorization is a precedent that we have seen with hydroxychloroquine. So it wouldn't be nonsensical to contemplate that in light of these new data. And frankly, I think we should. I would agree that we should wait for peer review. I think part of peer review includes the conversation we're having now and the conversation that will be had at the FDA and at hospitals around the country as we speak. And I think the outcome of that conversation will certainly put remdesivir in a light where it is viewed less effectively than it has been. And I mention that in the context of this drug being referred to as standard of care, essentially, until now, on data that looks like it's irreproducible.
Shepard Smith here. Thanks for watching CNBC on YouTube.